Welcome to this very interesting and hot session. By all means, it's a hot session. There is lots of people queuing outside, so let's be fortunate and enjoy the fact that we are all inside. This session is entitled Breaking the Calcium Ceiling in Bifurcation Stenosis with Contemporary Percutaneous Coronary Intervention. My name is Emanuele Barbato. I'm the current EuroPCR president from Rome, Italy. And I'd like to invite all the colleagues back in the row there. There are still chairs here in the front row. Please join us and come in front. So join this session if you want to better understand the role of intravascular ultrasound guidance in contemporary percutaneous coronary intervention of calcified coronary stenosis through the IVUS 1, 2, 3 essentials workflow. So we will learn shortly what is this algorithm. If you want to learn the proper atherectomy device selection technique in calcified bifurcation lesions, and if you want to join us in appraising the opportunity offered by DCB, drug-coated balloons in challenging coronary anatomies. What's in the box? 2 practice-oriented mini lectures, 1 live in the box from Clinique Pasteur Toulouse, and lots of shared experience. Ours, but most of all, yours. So try to make this session as interactive as possible. This is our team for today. I introduced already myself, Mirvat Alasnag from Jeddah, Kalavaini Mahadavan, Portsmouth, UK. I apologize for the pronunciation. That's easy. Antonio Mangieri from Milan, Italy. Ajay Kirtain from New York, USA, and Flavio Ribicchini from Verona, Italy. First, Mirvat, how can they talk to us? Of course, shouting, but how can they do for the rest?
Please do access the app online, and your questions are going to come through in your comments, and we'll find appropriate moments during the session to respond to them. There are also microphones in the hallway, so do stand up, and when there's a moment, we're going to reach out to you.
So, Ajay, why don't you explain us this algorithm? 1, 2, 3, stand up. Explain us how it works.
Yeah, no, for sure. Happy to talk about the algorithm and just use of IVUS and imaging in general. For the PCR staff in the back, there's 10 seats in the front. I don't know if they can hear me, but there's definitely seats in the front for folks who want. And this is going to be fun and a welcome discussion for everyone. I just want to start off by talking about imaging being underutilized, because I think we're hearing more and more about imaging at these conferences, but yet there are many people who say, I don't really need to do it. I'm an experienced catheterizer and angiographer. My outcomes are great. My patients do well. And I don't need to do it. And there's not adequate data to make me change. And I think more and more we're seeing now that that's not true. And I think you don't have to read every slide here. This was before Renovate Complex PCI. But there is a ton of data out there now showing that imaging changes outcomes. You can actually do better for your patients if you image them, particularly if you have complex lesions and stenosis, and that's what we're seeing nowadays with all of our patients in the cath lab. Okay, if you accept the fact that there's data, that's okay, but it's expensive, and I know how this should be treated. Imaging doesn't add anything other than make my staff groan about doing it. It's too costly, adds time and effort, and it's hard for me to figure out in many cases what I'm looking at. So it's easiest for me to fall back on my experience with angiography. I think this last part is where we're getting closer to the truth. Let's face it, imaging is not easy historically. These are the images that we were trained to look at with catheters that didn't cross stenoses, and then we were supposed to make something of it. But the truth is that the technology has evolved, and there are HD systems where you can see much more clearly exactly what you're looking at, the adventitia, the media, the type of calcium that's there, and the systems are easy to use now. So this is just an example of the Avigo 2 system, which is on a portable cart, that is much, much easier to use. You can actually watch people making measurements because there's screens on both sides. And the bottom line here is that you're right, that your eyes don't lie. When you were only looking at this, it was not easy to do. But now that you're looking at this, it's certainly worth a chance looking again to see if you can implement these in your clinical practice. Now, what do? We do definitely need to be trained. This is not something that's intuitive. You need to understand what you need to look at, but I can tell you it's pretty simple. It's not complicated in terms of what has to happen. What we do, and I'll show you an example of how we do this with a case in a second, is you basically identify what the lesion is itself, define your landing zones, you look at the plaque and assess what the morphology is, and they're very simple measurements, and I'll show you what they are in terms of how you assess exactly what you're going to do. That helps you pick your predilatation balloon, the type of device you're going to use for predilatation. It helps you pick whether you're going to do plaque modification further. It helps you pick your stent length. And once you do that, and once you make sure that you've cracked the calcium specifically enough to expand your stent, then you go in at the end to check your work. The idea here is to make sure you didn't miss a lesion, to make sure that the stent is not just hanging in the vessel too small for the vessel itself, and most importantly, to check the expansion of the stent. Because it's the expansion of the stent. Could you make that vessel big enough to then improve flow that impacts outcomes? It's one thing to get the stent to where you need it to be, but if it doesn't expand, it's actually worse that you put the stent in than didn't put it at all, and that's super important. So this is just an example of a case. This was a patient that had severe calcific left main disease. We can appreciate what the lesion looks like. You can argue, should you have talked to the surgeons, et cetera. We did all of that, and this patient actually came for a minimal contrast PCI because there was some renal insufficiency in the patient. So how do you do this? This is what the pullback is like, and most of you are familiar with non-automated pullbacks. The reason that we do automated pullbacks is when you pull back at a specific speed, that allows you to calculate a length of the lesion. So clearly this is a severe left main stenosis. We measured areas. You don't necessarily have to do that. You could tell that was tight. We actually pre-dilated this first to let the IVUS cross. But the way we do this is we go to the distal segment of the LAD. You all saw that lesion was in the left main. The standard strategy is going to be crossover into the LAD. So we go into a region of the LAD where the vessel looks normal. And you can see here there's a little bit of plaque, but the vessel is basically normal. But we don't just use the IVUS. We actually co-register in our brain and on the screen a cine, a dry cine of what we see on the angiogram. And that's where we know the distal stent needs to land. So very simple. Land the distal stent over there, measure the vessel size here, and that's exactly the distal reference diameter of where we have to put the stent and what the stent sizing is. We then pull the catheter back. This is the proximal landing zone in the left main. We can measure the diameter here as well. We then know what stent has to expand to that diameter. Fortunately, there's some good choices for that nowadays that you can size to the distal reference in the LAD and yet expand it big in the proximal vessel. Because there was calcium, we did further preparation. And by the way, this is how you do the length measurement, what I described. Distal reference looks like this, proximal reference looks like this. You simply take the distance between the two, that's your stent length. We then actually, as I said before, put the angiogram with the IVUS in our brain, and we know exactly where we need to land the stent distally and proximally. We wired the circumflex and did our predilatation with confirming that this actually cracked. You and IVUS again to be sure that you cracked. We put the stent in, do a pot. This balloon is sized exactly based upon the IVUS. So there's no guessing. Could it be 3.5? Could it be 5.5? No, it's 5.0 because we measured it to be 5.0. We do a final run to check our work. You see good expansion throughout. There's plaque behind that we measure what the left main area is, and you're done. And this is the way these cases ought to be done, especially for left main disease, complex lesion subset. There's clear anatomic and otherwise data showing that we can improve outcomes this way. This is angiogram final result. So we took one picture at the beginning, one picture at the end, no pictures in between. The entire case was done with 10 cc's. And it leads us to the existential question, which I put in as this 1, 2, 3 workflow. If your mother was having this PCI, would you not want her to have adjunctive imaging to guide or optimize it? And the answer is yes, you would. So if you would want it for your mother, provided you like your mother, if you would want it for your mother, why don't we do it for our own patients? And that's really what this whole session is about. Mirvat and I were fortunate to be able to write this document from the Interventional Council of the American College of Cardiology. So this is the American College of Cardiology Statement on Intravascular Imaging. Is recommended as an essential adjunct to angiography for specific lesion subsets. I won't go through them. It's all complex disease. But we also state is you need to get trained. So if you're only using it in complex disease, how do you know what you're looking at? You have to be able to do it in other cases so that you can identify those normal vessel segments, measure your distal diameter, measure the length, and do the case well. So with that, I'll conclude. I just want to thank you for listening. I'm certainly happy to see the case in this session, but I figured that would be a good way to start off this session. Thanks so much.
Thank you very much, Ajay. So we see IVUS to be used to understand whether we need to modify the plaque and which kind of stent we have to implant and whether the stent is properly implanted. Let's go to the video. I think you're launching it from there.
So this is a case of 73 years old man who's suffering from association of cardiovascular risk factor. And you can see that he has a severe polyvascular history, left carotid and atherectomy, TIVA, PAD, also revascularized in March 223, and he's developing actually angina pectoris CCS III, nearly at rest. And the echographia and the clinical examination is not relevant. There is no abnormality on the lab investigation. The ECG that you will show in the next slide is almost as considered as no abnormality, no frank abnormality. But it is, we go for a coronary angiogram because he has a severe polyvascular disease, and you can appreciate that he has a huge right coronary artery, which is dominant and with a slight stenosis, a mid stenosis on the left, on the distal part of the RAC. But when we go on the right coronary network, you will appreciate a very tight stenosis on the mid LAD. It seems to involve the first diagonal, but also the second diagonal, which is quite important, but which is very remarkable, is the importance of amount of calcium, a large amount of calcium, heavily calcified lesion. And so we will do it, we will tackle this lesion today with Didier and the team. In the other cranial view, you can appreciate that maybe the ostium of the diagonal, of the second diagonal, will not involved on the lesion. So maybe a Medina 110 on the second bifurcation, and there is no circumflex network, which is occluded. So the key clinical data today is that we are dealing with a 73-year-old patient, CCS III angina, coming from a very tight and calcified LAD lesion involving two bifurcation. And we will try to do the best for this patient, and the best actually is to make the best plaque preparation on this heavily calcified lesion and try to use intravascular imaging to have a guidance and to optimize our PCI today. So we go by a transfemoral approach. 7 French, because we keep in mind that there is 2 bifurcations. That's why we go by 7, and we will be in this more complex, we'll be more comfortable with the 7 French. And the objective, we keep in mind that probably we will go with a rotablator, Didier. So first we will wiring with the new RotaDrive guide wire, which is a new wire for rotablation developed by Boston in collaboration with Asahi. It seems that it is a very good wire for a frontline wiring and not to try to avoid exchange. So we will try to wiring the LAD with this RotaWire drive.
Okay, guys, so if you want, we're going to now start the case. And Benjamin is going to wire the LAD with this new RotaWire drive, more talkable, more deliverable wire. So meanwhile, if you have any comment, please feel free. Because the other option, Emanuele and Flavio, could be to use a regular wire and to go for a microcatheter exchange. Is it something that you do routinely?
Well, if I can spare a microcatheter, I would always try to do so. It all depends on how tortuous and long the lesion is. This is, I must say, we can anticipate that it's going to be a difficult lesion because it's long, it's tight, as Flavio was saying. There are several branches, which is typical of LAD lesions. So I'm very curious to see this premiere, we can say, of the new RotaWire, how it will perform. So I agree with you. Let's give it a try to see how this RotaWire works on its own before thinking to other options.
And what seems quite obvious with that wire is that you can clearly see by the way the tip moves that it's more torqueable. It seems to be more like a one-to-one response with the torque that you apply to the tip of the wire. That's something that certainly is going to help us and to promote the use of a single wire first to wire a very tight and eccentric calcified lesion, and second to deliver as we aim at the rotational atherectomy. So Benjamin, you are the one using that wire. In terms of tactile feedback, how would you analyze that?
It's so different from the legacy one. You can see it's very easy to use, a very high response to torque, and you can appreciate how we cross the lesion. You can appreciate how I can take the collateral, I take the first diagonal, the septal. It was very smooth to advance, very easy. So I think it's a huge improvement in terms of rotablation procedure. There is no comparison with his legacy RotaWire. And I'm very, very surprised about the performance of this RotaDrive wire.
We just passed the first diagonal, and you see when we approach the tightest part of the disease, it's a concentric 360 degree with quite deep calcium. You can see it to the degree of shadowing that we have on the LED, and there are some areas less diseased. Now we are more into the proximal LED. We're going to run it again afterwards just to better analyze the disease and what we obtain in terms of measurements. But we have extensive calcification, Benjamin. We have quite almost circumferential in the vast majority of the mid-LED. We're going to focus afterwards more on the osteum of both diagonal branches to better fine-tune our strategy. But already first, this is definitely a severely calcified disease. We need to prepare the plaque. We're going to discuss about the plaque preparation modality that we're going to utilize. Here is the second diagonal. If we make a pause just right here, we can see the amount of shadowing that we have, telling us about the depth of the calcium that we have, and more concentric calcification. The osteum of the second diagonal is a bit involved because we can, Benjamin, if you agree, we can clearly identify some calcific deposits just at the osteum of the second diagonal branch. For sure, there is a tight lesion. There is no doubt about that. And in terms of diameters, just at that level, it seems to be close to be free something.
Yes, let's kick off our discussion here in the panel, and of course, feel free to intervene if you like. We've been waiting quite a while, but let's now cherish this new kid of the block, this RotaWire drive. Apparently, if we see that used, it seems to fly within the coronary artery. Is there anyone who wants to share the experience with the current legacy wire? What are the challenges with the current wire, and why are we long awaiting this new RotaWire? Who wants to start?
I'm happy to start. I think that, look, everybody that trained with Rotablader, it's the tried and true method that's been used for a really long time. You really struggled with not just primarily wiring, but the most important issue is that if the wire were to come back, then to try to advance it forward, and that was a real issue. My feeling is that for severely complex tortuous lesions, you're still going to use a workhorse wire in exchange and do that method. I think that what we could see from that is that probably a dedicated workhorse wire would have crossed faster, but he could do it, but still because the wire has been improved. But in my experience, the biggest issue is that if the wire comes back or anything, that's when you need to be able to still have torque responsiveness and get it back down again. And that's really where the big improvement is with this device.
That's totally right. Mirvat, feel free to intervene if you have questions from the chat.
So a couple of comments came from the chat. One was about they agree that fluoroscopy is not sensitive enough and they want imaging. They do ask about using 7 French versus 6 French if you want to embark on radial. Using radial if you want to embark on rotablation. And really quickly, somebody's also asking about expansion criteria, saying that the Renovate trial used 80% and the Ultimate used 90% for a distal reference. And so what does the panel suggest?
Okay, let's start with the radial femoral story. Perhaps Flavio?
Well, of course, I prefer to go radial. If you start femoral with a 7 French, is because even if you don't say it, in the back of your mind, you are going to put 2 stents in this vessel. If you want to keep strictly provisional, then, and I think the rotablation is the best way to start with in this bifurcation, you can certainly try to go radial 6 French in this lesion.
Now let's move a step forward. We already heard our colleagues introducing IVUS, intravascular imaging. What did we learn from this intravascular imaging run? Any of you would like to take this one?
So sure, there is evidence of very diffuse disease. We have seen different sequences of the IVUS run in which it seems that the calcification are very concentric. I think that one of the most important predictors of rotablator use is the presence of superficial calcium. Another important point is that the vessel seems to be not so tortuous. I've seen a lot of disease involving, as mentioned by Didier during the registration, also the involvement of the second diagonal by the disease. So as you can see, we observe with the IVUS a lot of things that we are missing essentially with the angiography. It seems that the angio, the second diagonal is fine and the calcium seems to be only eccentric, but in some points at the IVUS evaluation we have seen that the calcification are essentially 360 degrees. So these are, according to my opinion, good reasons to do rotablation.
Before I move on and I ask here in the panel, based on the information we have acquired so far, what would be the next step? What would be the strategy to adopt in these patients? We already heard what will be the strategy from the operators in Toulouse. But let's hear in the room what is your preferred strategy. Now you know what is the angiography, you know what is the IVUS. Who of you would go right away with a rotational atherectomy? Please raise your hand. Let me see that. Okay. Who would give it first a try with a balloon angioplasty? Just a little try to see how it opens up. Raise your hand. Come on, be honest. I think more than that.
Who would use an IVL-based approach? So I think it's interesting, less people say that. From my perspective, the challenge with this case is the length of the calcium. You could certainly do it with balloon. You probably could do it with balloon. You could probably do it with IVL, but you're going to struggle with guide extensions and pushing and multiple catheters, et cetera. And so cases like this, heavy calcium is important. There was actually a comment in the chat about could you use the angiogram to define the thickness of the calcium? You could, with especially stent-enhanced systems for stent enhancement, but you won't know length, circumferentiality, and whether it's superficial or deep. So unfortunately, there's no substitute. And fortunately, we have a good technique and a tool, and they really had a nice demonstration of the longitudinal view, the measurements that can be taken with the IVUS system.
Let me hear Kala Ivani.
Yeah, Vani for short. That will make it easier.
Oh, that makes it easy.
Yeah, no.
What would be your strategy, Vani?
I mean, looking at the IVUS, actually, if you look at an IVUS-based calcium scoring system, you know, if you add together the fact that you've got more than well over 5 millimeters of calcium, you've got 270 to 360 concentric arcs, and the distal vessel itself, where they're planning to land the stent, is a diameter of less than 3.5 millimeters. The calcium score by IVUS is actually very high. It's coming out at probably 4. And if you look at the retrospective data analysis that's been done, atherectomy techniques significantly improve stent expansion when you've got a calcium score of more than 2. So I do agree that I think actually ROTA is a good strategy here.
By show of hand here in the panel, who would start with a 125 millimeter bar? 1.5 millimeter bar? 175 millimeter bar? Who would start with a 125 millimeter bar? 1.5? 175? It reflects perfectly what's in the panel. Let's go back to Toulouse and see what they used.
So we're ready for the rotational atherectomy. So we have selected a 1.5 millimeter burr. We may discuss and describe the rationale for that afterwards. But let me just guide you through the main components of the new RotaPro device. So it's really more ergonomic, allowing at the end a kind of single operator procedure. So that's very, very interesting. It's a real improvement for us. So what you see on screen, so here we have the burr that didn't change at all, but it's more about the turbine that is a little bit different. So we have the advancement and retraction knob that houses at the same time the on-off button for the rotation. We may advance and retract as we did in the past, but on top of that, you can see that blue button. And then more proximal, what we see here, that black knob is just a brake release knob, so we may utilize it depending on the frictions that we have into the system. And what is also new for this RotaPro system is that DynaGlide activation button. So we just put on it, and at the end, Melody is going to press on both buttons at the same time just to activate the DynaGlide feature of that RotaPro system.
Benjamin, one question to you regarding this new RotaWire. One of the problem we used to have with the old one is the easiness to kink this wire. How do you feel in advancing this bar on the RotaWire? Do you feel it kinks, it deflects easily, or is it more stiff?
Definitely, I think it's there is no prone to kink with this new guide wire. The feeling in the end is much better. But again, there is two kind of wire with this new RotaDrive. There is a floppy one, but there is also a stiff wire. Advantage with both. The stiff one is when you want to tackle longer lesion, but we use a floppy one in this case because there is some tortuosity to avoid gate BAs. But definitely, the feeling of the risk of kinking is not the same than the previous one.
So which technique are you going to utilize, Benjamin?
Always the same one, Didier, picking technique, very short run, 10, not more than 20 seconds to avoid slow flow. We know that when you make rotablation cycle more than 30, you expose your patient to slow flow and no reflow and complication. So always to try to make a picking motion, and after I finish actually my strategy with a polishing run.
Okay. So we have this, you're going to see, for those who are less familiar with the rotablator, that we have three kinds of feedback. Benjamin has a tactile feedback. We have this audio feedback that tells us if the speed is going to decrease more than 5,000 or 10,000 RPM. We want to avoid that in order to prevent any burr entrapment. We have as well this visual feedback. What kind of resistance did you experience so far?
For the moment, I don't have any resistance on the proximal part, so that's question the size of the burr. But when we go in front of the second diagonal, and you can see on the screen and the calcium on the osteum of the second, I feel some resistance. So that's why I just go on the picking motion more intensively at this level. Not try to avoid to cross in one time because you risk to entrap the burr. You can feel and you can hear actually the resistance. We are on the proximal part of the tight stenosis, and go slowly, very short run, try to engage the lesion. Please not try to cross because in this tight lesion we will be trapped with the 1.5.
And so you gradually increase the pressure on the lesion,
exactly,
run after run. And Flavio and Emanuela, I'd like to get your input in terms of burr selection. Does it seem appropriate to you? And does it impact the risk of entrapment, the risk of burr being trapped after jumping too easily after the lesion?
Oh, well, the decision of the bar size, it's very important. I think you have taken the right decision, staying on what you have measured is the distal size of the vessel, which was about 3 millimeters. So your choice was the 1.5, which makes the procedure very safe. We have to assess whether this run is effective because indeed the MLD that you measured was a little bit about 1.5. So it might be that it's not enough to crack the superficial part of the calcium. So this will be the next step to verify either by IVUS or by a balloon inflation if you have a good expansion, because otherwise you might need to upsize the bar a little bit more to be effective. That's the only point we have to understand at the next step.
So same technique, picking, small runs, short runs, 10 seconds.
Same technique, and Didier, you can hear that definitely we touch the proximal part of the lesion with a 0.75. We are certainly downstream with a 1.5, and it's an important improvement. You will see in IVUS that the preparation was incomplete, and the hair coming from the burr confirm that impression.
Okay. So let's go for, do you feel more resistance now as compared to the first one, even in that area?
Yeah, even it's in this area, much more resistance in the feeling. So the burr is working.
Okay. Okay, we could see that small jump when the burr passed the distal lesion. So here is the new IVUS run after the 1.75 burr. We can see that distally, we are quite distal to the lesion. There is no real dissection. There is still that plaque that we see with a little bit of calcium here. Then starts the real disease part. We could see some cracks into the calcific deposits. So the minimal lumen diameter is slightly bigger. We could see another crack coming in the diagonal branches, a crack just on the opposite wall, here another one, more proximal into the LAD, and yeah, it seems to be more appropriate in terms of lesion preparation.
There are two aspects that I'd like to discuss with you at this stage. The first one is the technique applied for rotational atherectomy. It was a compendium of tips and tricks. And the second one is the degree of plaque modification achieved after the 1.5 and 1.75 millimeter bar. Let me start with Antonio. The technique in general, but in this specific case where we have a long calcified lesions, what should be done to have a proper rotational atherectomy technique?
Okay, I think that essentially what is shown by this case is the correct application of the packing motion of timing, correct timing of rotational atherectomy use. You don't have to run too much. You don't need to have a very long run of rotablation in order to minimize also the risk of distal embolization. And the other important aspect is also the speed of the rotablator. I see that sometimes they have modified the speed during the run of rotablation. I prefer essentially to go a little bit higher, around 2000 rates per minute, and to be stable during the crossing of the lesion. But I think it depends a bit about the school. I've always done this, and I think that if you reduce a little bit the run of rotablator, maybe you can have a little bit more the risk of rupture of the vessel, and sometimes you can also have the risk of barrel entrapment. I prefer to have higher speeds during these runs.
Let's hear if there are comments regarding the technique of rotational atherectomy from the
several
colleagues.
questions. Some Antonio has already addressed, but two that have not been addressed so far is we're talking about bifurcation. So how do you protect the side branch, especially for the left main? And the other one is how do you size the burr itself? How do you select the size?
Let me distribute the question. Flavio, bifurcation.
Well, one of the major advantages of using rotablation is that you don't create plaque shift. So it's the safest way to treat a calcified bifurcation without impairing the side branch. And of course, when we use rotational atherectomy, we never implant two wires, okay? So you trust on the device and you leave the diagonal and it will remain open. Then, of course, if you dilate with balloon, it's another story. Then you might need a protection with a wire. But this is the safest way to address a bifurcation with calcium.
Vani, about the bar size selection.
Yeah, so I think this is where imaging actually is really helpful and pretty crucial in that if you're going to size your whatever adjunct you're using properly, then you need to know the diameter of the vessel accurately. So for rotablation, I've always been traditionally taught to go for about 50 to 60% of vessel size. So in this case, somewhere between 1.5 and 1.75 would have been fine. Of course, you've got a size match between the distal lesion and the proximal lesion, so they've used two burrs, which is entirely appropriate. But the other important thing to remember is obviously where your wire bias is when you're rotablating, because even if you've got a slightly bigger diameter data that's available, if the bias is towards the nodule or towards where the calcium is maximal, you'll get a bigger effect.
Now I'd like Ajay to help us in applying the 1, 2, 3 algorithm at this stage of the procedure. So did we do a good job so far? What is the analysis of the IVUS you have seen after rotational atherectomy?
Yeah, I mean, I think the fractures were great. I might have done the IVUS run, as you mentioned, after the 1.5 or tried an NC balloon after the 1.5 to see if that was sufficient cracking. I think that the key thing for this case is you already know your lesion length. You probably haven't extended it very much. You've achieved your cracking of the calcium. So take NC balloons just further at that point. I don't know if you have to go with IVL once you've already used 2 devices, and the NC balloons alone should be sufficient. Just one last thing I would mention is that this should be mentioned, the business about adjusting the burst speed during the run, that's not typically our practice. You saw it with the 1.75, they did not do that. And the reason is that you generally want to see the decelerations. So if you see the decelerations, then you back off. So that's an interesting practice. I'm sure they have a ton of experience doing it, but that's not what I would recommend.
I can only share the same attitude. I'm not adjusting the speed. I'm adjusting the speed when I change the burr, because sometimes you can have a downgrading of the speed, but just at the beginning. But once I start, I keep the speed. Are there questions from the chat before?
I think a question that we haven't addressed yet is about if you're going to do it in the right coronary, about using pacemakers or aminophylline.
Who wants to take this one? Right coronary artery or dominant circumflex need to pacemaker?
Well, generally, no. It's very unusual circumstances, and you can fix this with a dose of atropine. It's very difficult that you need to pace for a long time.
I think also aminophylline in the flashing bag could be a solution in these cases, and we are not using anymore the pacemaker.
Yeah, I would agree. I just say for operators that are not used to doing a lot of this, though, there's a lot of things going on. And so I actually think that for operators that are starting off, there's nothing wrong with putting in the pacemaker just so you can focus on the things that you need to focus on. I think experienced operators, we don't typically do it. But to start off, the last thing you want in your first rota case is asystole and heart block, which happens rarely. And then it'll prevent you from saying, I want to do a rotablation ever again. That would be a mistake.
No, of course, unless you start with the patient with 25 ejection fraction, LBBB, and advanced AV block, of course, something will happen. But except if you have normal conduction, you don't need it.
Let me bring you back to one of the first moments of our session when I asked how would they tackle these kind of procedures in the room. There were different options there. Someone said, I would try balloon first. Some others said rotablator. Some others said IVL. I suspect Flavio, in his presentation, has some practical algorithm that we could share with our colleagues, and you could deliver. Yeah, that's the moment. We recently published with Flavio the EuroPCR, Euro 4C EuroPCR consensus document.
Yeah, thank you, Emanuele. We are very proud of this. It's a work that took more than a year of a group of experts, and is going to be published in the European Heart Journal in the near future. And so we can, for the first time, show you, and you can also take pictures of the algorithm, which is based on the use of intravascular imaging, because we also have an algorithm for those who are not so lucky and don't have intravascular imaging, and the procedure is guided only on angiograms. So I would show you 2 cases of bifurcation in which the intravascular imaging with IVUS has helped me to take the decisions. This is an old man, symptomatic for stable angina, and with normal LV function and normal renal function. So you see, it's a case done several years ago. We did the diagnostic angiogram before from the radial, and it was very difficult to engage the artery, so we decided to go with a 6 French from the right femoral. And it's a clear bifurcation. You don't need IVUS to say that this is very calcified, and it's a Medina 111. It's a large circumflex, and it's a large territory in the LED, and it's a very asymmetric plaque. So there is no doubt that you will need something to cross this lesion, and of course, after a mild predilatation, because the IVUS catheter does not cross these kind of lesions, we can do together the analysis of what we see. And of course, we did first the analysis of the LED that, as expected, shows a lot of calcium, very deep, very irregular, taking at least 180 degrees of the ostial LAD. And then is the circ, which looks even worse. You see there are spikes and nodules of calcium in the ostial part. So what is this saying? Of course, we knew it was very calcified. This is something you get also from the angio, but that both ostia are involved, that the calcifications is very deep, the vessels are very big. So in my mind, this is already, although I am a 90% provisional operator, this is one of the cases in which I start thinking and putting 2 stents. So step by step from 1.5 before up then 175, doing the rotational atherectomy, first on the LAD, then on the circumflex, once at a time. Put 1 wire on the LAD and then remove it, put the wire on the circumflex. Some operators say that you can put 2 wires in large vessels like this, but sincerely, I don't recommend that. It takes a while and you change your wire and you avoid the twisting of the wires with the rotablator, what can be very severe complications. So rotablation is one of my favorite to prepare this vessel, and then this is the final angiogram after culotte stenting, pot and post-dilatation. And let's have a look at the IVUS. This is what we are interested on to assess the final result. You see the good expansion of the stents, although, as you can see in the lower central image, there is an asymmetric expansion. There is still calcium. You will not get rid of that calcium. This is nodular, and the risk of even further dilating this 84-year-old male with a very big balloon at very high pressure is the risk of coronary rupture. A rupture in the left main means that if you put a cover stent, you will occlude the circumflex. And so this is something we don't like to have. But the images are quite rewarding. Then this is the pullback from the circumflex, which is actually even better. And this is one of the things that Ajay was saying. I mean, when you treat a left main, having this final assessment showing you good stent position, good expansion, although might be a little bit asymmetric, but with the large final MLD gives you the certainty of a good long-term follow-up. So there is no reason to avoid that. We have IVUS in left main as a 2A indication in the European guidelines, and our friend Adrian Banning is running in Europe a study which is called Optimal, which has, I think, just finished the enrollment, which is a randomization on IVUS-guided and angio-guided PCI in the left main. And we hope this will provide the requested evidence on randomized trials supporting the IVUS use in left main. The second case is, again, a case of a bifurcation with calcium, Medina 111, in which the IVUS was very useful in taking the decision, like in this first case. I want to underline that with normal LV function, in this complex case, we didn't have any kind of hemodynamic impairment, and the procedure was well tolerated. Again, IVUS, I like IVUS because in these old patients you don't give extra contrast. It's a contrast-less almost procedure. This is younger but sicker. You see that there is an impaired left ventricular function, and it's a patient with unstable syndrome. So it's totally different to the previous one. And again, fluoro is telling you that there is a lot of calcium. We know that we cannot trust the analysis, the severity or the difficulties that we will encounter. Sometimes cases like this you can do with balloon, and sometimes you find that they are totally uncrossable. So in this case, again, the angiogram is telling clearly that the ostium of the LAD is involved, but we have to assess better the ostium of the circumflex. So based on these images, I have no doubt to interrogate the lesion with intravascular imaging and take the decision whether rotablation will be my first choice or a cutting balloon as an associated device after rota, and whether to use 1 or 2 stents. So again, this is what IVUS is telling us. If you start from the left, you see that the ostial LAD has a 360 involvement with deep calcium. You can say it's deep because you see the shadow all around the vessel. When you get to the bifurcations, it's very, very complex. You see how asymmetric it looks. The ostial left main has some calcium. And then the run from the circumflex shows it's a very big vessel, and at time 6 you see there is a clear nodule, which be, of course, difficult to expand, but the area of the proximal circuit is rather large. So on the basis of this consideration, we have 180 in the ostial LAD, calcified bifurcation, and only mild calcification on the ostial circ, which is only based on this nodule at time 6. So the strategy was testing the lesion with a cutting balloon, and as you can see, there is a good expansion in the proximal LAD despite this 360 degrees calcification. And then at that point, since the ostium of the circ was not so involved, we implanted the stent going to the circ, but leaving the room to the LAD in case you could need rotational atherectomy. So the stenting of the ostial LAD and then testing the ostium of the circ with the cutting balloon. And the cutting balloon is expanding well. So at that point, I decided that you don't need to do rotablation on the circ. And so now the two vessels are well prepared, and this is the second stent. So it's a T-stenting. The first one went from the ostium of the LAD to the proximal, and the second one goes from the ostium of the left main to the proximal circ. Then is, of course, the kissing and the pod, and the final assessment. Again, you see that the LAD is symmetrically expanded. Of course, you will not make this vessel a 5-0 because of the severe calcification. The left main bifurcation looks nice. The ostial left main shows the stent is well opposed. And as expected, the circ has a good expansion of the stent. This is the final angiographic. And the conclusion are, again, underlying the importance of IVUS in deciding the strategy in a bifurcation. In this case, the efficacy of cutting balloon, which cannot be anticipated. You have to try and look at the good expansion. If it does not work, of course, you have to upgrade to something which is more effective. And in this step-by-step approach based on IVUS, of course, help in several conditions, many conditions can help you in decide whether to use one or two stents. Thank you. And this is
that's
the
just
scheme.
for the
we leave it for you. I mean, it will take a while. We had a dedicated session early this morning, and Josh Yonuma went step by step. Oh, no, please leave it for a while. Thank you.
They are pushing on us.
Thank you. Okay, just for you to take the picture, and then you see it at home. Thank you.
Okay, let's go back to Toulouse and see how they proceeded with their case.
Okay, here we are. We can see, we can identify the spasm more distally, but let's prepare the lesion of interest. So it's a free 0/20 non-compliant balloon.
And you can appreciate that there is no indentation, maybe a slight indentation just in front of the ostium of the diagonal.
18 atmospheres.
3 millimeters is at least the diameter.
Yeah.
And probably, Didier, we would have to improve to 3.5 between the two diagonal and
more
4
proximal.
in the proximal part.
With you. So this was 20, just in terms of length, but we have the IVUS as well to tell us what is the length from a lesion-free zone distally to a lesion-free zone more proximal.
Okay, you can appreciate that there is a slow flow in the diagonal, in the second diagonal. There is still the spasm on the distal LAD.
Maybe we should prepare the ostium as well.
For sure, this is a huge diagonal. The risk of lose it before when we implant the stent is high, so maybe we're gonna protect this ostium. Okay?
Do you agree, guys? Okay, so this is what we have. So we will have to decide afterwards what we do on the distal portion, whether it be spasm or if we think is a new lesion. I would vote first for more spasm. But if we focus on the lesion of the area of interest, first of all, the diameter, the length of the stent is okay. 48 is going to cover everything according to the IVUS guidance. So we are in the disease-free landing zone distally. So maybe we can expand here to start with. So it's a 30 by 48. And I will go very gradually. As it is a quite long stent, we will have to wait to have a nice expansion. We're going to expand it first to match the distal diameter of the vessel in order to prevent any extensive dissection distally. So I'm just at 12 atmosphere, and then we'll post-dilate first, do the IVUS run, and then decide on what we have.
In fluoroscopy, we have the impression that there is no indentation, especially on the distal part of the lesion, which was a heavily calcified part, and the more tight. So let's do for a pot, and I think the IVUS can give us the size of the balloon. Maybe on the mid-LED we go on a 3.5, and on the proximal part of the LED, 4 millimeters. So you can appreciate that the 2.5 millimeter stent crosses really easily the bifurcation. And we are now on a two-stent strategy, but bailout. So of course it would be a T and protrusion technique. So because we are small diameters of vessel, I like to engage my second balloon before placing the side branch stent to avoid to be some difficulty to cross forward after. And what should be very important is to place the proximal part, not to avoid too much protrusion in this mid-LAD.
Perfect. I think we will be okay.
C'est bon là, hein? What do you think about the location of the stent?
It looks very good, Benjamin.
Okay. So let's go. So Melody, you can expand the stent. Let's go at 10 atmospheres to start with. Yeah, just to prevent any distal dissection of the diagonal. You can move up to 12 atmosphere, I think. Okay, deflation, and then we're going to be more aggressive by backing the balloon of the stent. So then we're going to go at higher atmospheres, still paying attention to the position of the wire, as Benjamin is doing here.
Okay.
And now you can go up to 18. Perfect, to make sure that we have a nice expansion, proximal. Okay, deflation.
So this will be a mini crash.
And then we're going to go afterwards to a kissing inflation. Okay, let's go to 10. Hello. You first. Okay, 10, 12. You can go up to 18. And I have a non-compliant balloon. Okay. 1, 2, 3. Okay, so here is the last IVUS run. You can see distal to the TM protrusion. We saw the neocarina. We're going to come back to it afterwards. That was wide open and well expanded. In the mid portion of the LED, Benjamin, there is still some residual plaque, but the MSA is okay. So maybe you can stop here and just come back to the neocarina just to see what we have. We can clearly see the scaffolding that has been obtained with a minimal protrusion of the stent at the diagonal within the LED, because it's only on a couple of millimeters that we see that stent within the LED. So it tells us that you did properly position the stent in the diagonal. Nice expansion. And if we go back now to the mid LED, we can see that the surface is 6 millimeters square, so which is very nice given the amount of disease that we had for this vessel. So maybe if you agree, guys, we can provide some nitrates to the patient and do a final root shot just to see angiographically what we obtain.
And it's improving. Look at this.
Getting better.
Yeah, it's much better. So maybe you can give the final word.
We'll give the final word here in the panel. So, nice case. Complex. They actually made it easy, but just because they optimally used all what they had at their disposal, so imaging, rotational atherectomy, further balloon dilatation. There is one aspect we didn't touch, which is regarding the bifurcation technique. They used a two-stenting strategy. We might agree, we might disagree. But what I'm interested in, and perhaps we can start from the right side of the table, what about the role of drug-coating balloon in the side branch? Does it have a place here? You know, it's already a lot of calcium there. It's a long lesion. You might want to avoid additional metal. Is there any room for this technology?
Well, it's a very appealing option, but unfortunately, we still don't have clear evidence supporting that, and the industries are not supporting these use.
Midvat, any comment or questions from the chat?
Well, a couple of questions really related to wire trapping and protecting side branch again when you're rotablating, but really trapping wires in side branches in calcified lesions or jailed wire technique.
Well, I think Flavio already expressed his opinion. I personally feel to share this opinion. I don't know if anyone else in the panel has a different one. It's already so complicated, this procedure. Why do you want to make it more complicated than it is? We learned that if there is one advantage of rotational atherectomy over balloon-based strategy, is that the risk of plaque shift is lower. It's not zero, but it's lower. So let's do confidently this procedure without a protective side branch wiring.
To clarify, that's putting in the wire while you're doing the rotablation and all kinds of crazy things you can do to protect the wire. But once you've done the rotablation, of course, you should have the wire in the side branch so that you know where it is. And all the standard jailed wiring issues, they don't really, I think this is best practice at this point. Don't leave big side branches like that unwired.
Now, one step forward, and then we move towards the conclusion, is the IVUS analysis of this stent implantation. We'll learn from IJ this algorithm, 1, 2, 3. We are in the post-stenting setting now. Anyone wants to comment on the implantation of this stent? Antonio, Vani?
Essentially, it was a very long stenting. The only thing that I do differently, they did an IVUS run immediately after rotablation. I prefer to do the IVUS run after rotablation plus predilation. Essentially, the decision that we can have after predilation is there are enough cuts in the calcium or not. Because rotablation essentially paves the way for the passage of balloons and other materials. But I think that it's important to see how many cracks we have created in the calcium. And so the only thing that I can say is maybe I would have done another run after predilation. I think the result is okay for this case because it was a quite complex case.
Yeah, I actually think that was a great point because that proximal part of the stent before the bifurcation, look, the MSA was all right, but you have to beat a lima. And so you might have considered, after seeing it then, doing cutting balloon, doing IVL if you need to really be sure that you've expanded well in that proximal segment. The only other slight comment, Vani, that I want to make, sorry to interrupt your speaking, is that make sure you pick a long stent, the appropriate stent, so that you can expand the proximal to as big as the proximal vessel is. That was a 3.0 stent. It may not go to as big as you need to get it, so we have to pick the right stent type.
What would be your choice in terms of stent in these cases?
You know, to be honest with you, have the chart on the wall and look at it that way. I don't think I'd put a Megatron in it because it wasn't really 3.5 distally, but the Megatron has a very nice expansion capacity up proximally.
In the interest of, let's say, completion of information, this is an edited case, and I can assure you that the colleagues in Toulouse did IVUS pullback at each and every step of their procedure. So even if you haven't seen that on the screen, they were performed, but I had to squeeze a 2.5 hour case in a 20 minutes case. So just to be completely transparent. I think we have 1 minute left. Allow me to just wrap up the session. We learned a lot, I must say, from the colleagues and from the discussion and from your contribution. First of all, on the key role of intravascular imaging, IVUS in particular, in this complex coronary setting. It is very simple to adopt. If we want to address key questions, we just need to follow a stepwise approach. IVUS can help us at every step of the procedure, before, during, after. Second thing that we learned, at least I enjoyed following, is the proper application of rotational atherectomy in a long calcified lesion with bifurcation involved. We have seen how safe it was. The slow flow that you see, we have seen in the diagonal branch was after further balloon dilatation. We didn't see the slow flow in the diagonal branch after rotational atherectomy. And that is for us also a very important take-home message. With this, I'd like to thank all the colleagues here in the panel, Mirvat, who helped a lot with the discussion, and you all for attending this session. Thank you very much.